So welcome everyone to this webinar online conference organized by the journal Water Emerging Contaminants and Nanoplastics. I'm pleased to introduce Professor Konstantinos Makris, who is going to deliver a lecture. But before we start, just a short presentation about his a short CV of Professor Konstantinos. Please correct me if anything is wrong, but he's Associate Professor for Environmental and Public Health at the Cyprus University of Technology. Previously, he has been also Adjunct Assistant at the Department of Environmental Health at the Harvard University. And his main field of expertise is exposome-based water and the connection between water and health, the basis of the exposure to chemicals and other pathogens, etc. In this field, he has been working in different countries like Cyprus, Greece, France, Kuwait, the Netherlands, or Norway. And he is also member of the editorial board of this journal, that is Water Emerging Contaminants and Nanoplastics. As regards to the talk he's going to deliver, he will talk about the drinking water, and specifically drinking water and public health in the urban centers of the 21st century, and challenges and opportunities. So, Konstantinos, I'd like to give you the word. The floor is yours.
Thank you, Professor Ginebreda, for the kind introduction. I appreciate the invitation. It is my pleasure to share my presentation. Please give me a few seconds. Okay, can you see my presentation?
Yes.
Yes, we can see. Okay, thank you. Thank you very much. Today, I'm going to talk to you about a classical topic, which has to do with the drinking water quality and public health issues, particularly in urban centers. And I will explain why I'm focusing on the urban centers of the next century. I believe during the 20th century, we're able to solve some problems that relate to water and health issues. But now, there are some challenges, I would say also opportunities, during the 21st century that relate to water and health issues that we should pay particular attention in order to continue providing safe and clean water to all, particularly to urban centers. So I'm going to declare that I have no conflict of interest of any kind and say a few things about my team, the Water and Health Lab team. What do? We basically generate biomarker data that relate to drinking water and also to biomarkers of exposure to various environmental stressors. And this is also accompanied by additional measurements that relate to biomarkers of biological effect, oxidative stress and tissue damage, inflammatory response, and also metabolomics platforms that help us to make better linkages between specific exposures and some specific outcomes that relate to human health, in order to better understand the biological processes that relate the external environmental exposures to the internal biological processes that are responding to the external stimuli or stressors. So by generating this data, we're able to also process this data, applying appropriate biostatistical models. And at the same time, we also pay a lot of attention to translating research findings via dissemination, communication, and exploitation activities using traditional media and also the social media. Okay, so today's talk is going at large to rely upon a recent chapter that I wrote for the Wiley Encyclopedia on Water about drinking water and human health challenges in the 21st century. So I will start by talking about some state-of-the-art and some challenges that relate to water and health, how climatic and other drivers might influence human health, some persistent and some emerging factors that relate to drinking water quality, continue with some opportunities and challenges that relate to the topic, and close with some take-home messages. So following a more holistic view was actually the wish, and I would say the findings of one of the fathers of medicine, the Greek Hippocrates, who actually was the first to mention the importance of linking the environment, the climate, and human health in his epic work Peri Aeron Hydaton Topos. So the focus here is not to see water issues alone, but look at them together with other environmental media like air, soil, or diet, or other factors that relate to people's habits, behaviors, workplace exposures, because by doing so, you are basically coming closer to the understanding of how truly the various exposures co-interact with each other in one's routine and everyday life, and how they collectively interact and influence the disease process, or not the disease process if we talk about the healthy individual. So this, of course, is under the umbrella of public and environmental health major questions, which is to answer why some people get sick, why some people don't get sick, and why some others have more severe, let's say, outcomes and some others don't. And does that relate also to drinking water quality? Yes, it does, because as we know, historically, there are several stressors within drinking water that influence human health. And actually, these contaminants that are present in drinking water, they happen at the same time to also find themselves in other media like food. For example, arsenic, pesticides, other environmental, let's say, contaminants of interest in microplastics or PFAS. These are some prime examples of, if we want to understand the sources and then the environmental processes that govern the fate, transport, and eventual contact with the humans, we need to account for all these various sources. Otherwise, we will not get closer to answering the previous major question that I talked about, and how, for example, water stressors could be responsible for our health or not. So by collectively considering these aspects, this is what the exposome, the human exposome definition, tries to answer, by collectively capturing the cumulative influence of all environmental exposures throughout one's lifetime, from birth until death, including the endogenous biological response. So, coming to the urban centers, it is very important to understand the pressures that urban settings currently face. There is an increasing trend, but currently half of the global population lives in cities, and these cities expand. The encroachment of these urban centers is a very frequent phenomenon globally. You can see this map, this global map, the growth rate, how it increases from the lowest growth rate, let's say, of a green color, how that progresses to the yellow color, and you have some orange and red color, particularly in Africa and Asia, as you can see. So these are urban centers that are particularly impacted by enormous and highly significant growth rates in the population. And it has been predicted also by the World Bank that until 2050, 7 out of 10 people will live in cities. So why would drinking water authorities, drinking water scientists, public health scientists should care about this phenomenon that deploys in front of us? The major issue is that the infrastructures that are available to convey and distribute, let's say, clean water and safe water to the residents is typically old, and they are aging. This has been set up in the cities back in the 50s, 60s, and coupled with the growth rates that we just mentioned, the perimeter of the cities grows and the radius of the residential areas grows externally towards, let's say, the peri-urban areas, where there you might not have an infrastructure. So you might be delivering water that comes from different sources, or maybe it's the result of different technologies, or maybe can be the result of different treatments. Therefore, you start having in the city not a single quality per city, but instead of that, you are increasing the disparities in drinking water quality. I'm not going to talk about the health disparities that come also along with it at this stage, but focusing for now only on the drinking water disparities that take the form of variable, let's say, water quality or variable water availability, depending on which part of the city you live in. These issues can be exacerbated in areas that are particularly affected by the climate manifestations. Call them floods, call them droughts, call them seawater level rise, call them earthquakes. These are all very harsh, intense natural phenomena that impact also on water quality and maybe on drinking water quality. And this is something that we have not paid, I would say, much attention as we should, as we see that these climatic manifestations are more frequently appearing and they are characterized by higher intensities and also higher frequency and maybe also prolonged duration, so they last longer. Obviously, these manifestations influence the water infrastructures, influence the availability and the reliable provision of water, also the treatment facilities, etc. So these issues are actually part of all these discussions that take place as part of the Sustainable Development Goals, as part of the Sustainable Cities movement, Healthy Cities movement, and the sustainable water use has sometimes attracted some attention and in some others it hasn't. People, I would say some people might not take that seriously this topic, the topic of sustainable water availability, use, reliable availability throughout the year for all urban dwellers. So these topics that I'm just describing have not been adequately resolved even in Europe or in the US or in other parts of the globe. So it's also the case that within the city where you have all these green dots, all these households distributed, let's say, in the same city, they might be receiving water of varying quality. Why? This is going to be also a topic of my discussion today, because at first of drinking water pipe distribution systems, or more, depending on the size of the city. And these actually would influence the finished water quality that eventually reaches the households. And indeed, I would say that Europe in particular has long relied on the success of post-World War II infectious disease eradication programs and interventions, such as chlorination or the deployment of water treatment plants. So this actually has allowed people to rest on this success, and some other hidden or emerging risks that are part of migration issues, urban encroachment, climate change, all these, I would say, global drivers not allow yet the regulatory authorities to seriously shed light on how these factors would eventually influence the drinking water quality. As such, in a review we conducted almost a decade ago now, we had realized that only a small fraction of the available birth cohort studies in Europe had included exposures to water contaminants in the design. So these cohorts are very important studies that study not only water contaminants, but they usually study other risk factors of health, such as behavior issues, dietary, lifestyle, exercise, you name them. And our study actually showed that only a small fraction of these cohort studies, these very important cohort studies, had important and well thought of and designed data on water exposures. So that was an issue that we actually identified almost 10 years ago, and I would say the situation has not much changed since then. So obviously this low hierarchy score of water and human health issues in decision making and also in research funding has also influenced the kind of studies that come out of European research teams. The emphasis, for example, on air pollution and health issues is very important. By no means I'm trying to undermine or underestimate the importance of considering air pollution topics, but it is this collective and multiple exposures that people are commonly exposed to during their everyday lives that we should pay attention. And that's what my key message is here, that we need to proactively try to holistically capture all the relevant exposures from water, from air, from food, etc., if we want to get closer to the disease process and the disease pathogenesis. And as mentioned before, it is the human exposome concept, the methodological framework of this theorem that I explained earlier, and my lab is basically working on that and trying to apply this in real studies, in real life conditions, where we can actually try to understand people's environment at school, also at their home, and the water exposures, along with other exposures, nutritional, social network, chemical exposures, behaviors, lifestyle, and try to collectively study them in time and in space. This is what my lab and other labs in the globe are actually working on by trying to apply this exposome concept in environment and health cohort studies. And why we need this kind of studies? Because we have data that emerged during the recent years. I mean, it is the famous Lancet Commission on Pollution. It has been led by a very good colleague of mine, Professor Landrigan from Boston College, who actually chaired this Lancet Commission in order only to identify some very interesting facts. So they estimated and they calculated that human exposure altogether to polluted water, air, and soil kills more people than what a high sodium diet obesity, alcohol, traffic accidents, and malnutrition actually results. So if you think this at the global level, it's astonishing, because we usually consider that dietary, obesity, alcohol, all these risk factors, we thought that would be way more important with respect to the mortality burden of disease than polluted water, air, and soil. Nevertheless, at the global level, this Lancet committee showed this very interesting first fact. Secondly, there are some other interesting facts that the annual incidence of drinking water quality, either of chemical or microbiological threats in drinking water, these annual incident estimates exceed current prediction models. So this means that we have some increasingly unreported drinking water health violations that may be attributed to some new chemicals or some toxins that come from cyanobacteria, for example, Legionella, it's also very important, that usually are not typically reported and they just stay under the radar. So this was a very serious governmental report from the USA, from the Accountability Office, that actually alarmed about these unreported health violations that relate to drinking water distribution systems. These are typically incidents of drinking water violation rules that occurred within the drinking water distribution system and after leaving the treatment plant. And of course, this may not come to surprise for some of us, because we see that almost half of the water quality problems in urban centers have been attributed to contaminants, either chemical or microbiological origin, that have been created in aging water supply networks or aging distribution systems. Prime examples of that are copper and lead. You probably are aware of the major lead poisoning that took place in the city of Flint in Michigan and resulted in a series of court litigation cases. And this was a very important case study of water pollution that occurred due to a distribution system because of the lead release from the aged lead pipes that were part of this city's infrastructure, that led to this unintentional mass poisoning with lead. And as you know, lead is a very potent neurodevelopmental toxicant that influences the central nervous system and is particularly important and potent for vulnerable population groups like children. So these are some, I would say, facts and some trends that we see in the globe that, for me at least, they ring a bell that we need to pay more attention into the drinking water distribution system status of water quality. Here, I put together some examples of drinking water violation case studies that emerge as part of release of chemicals and particulates along with biomass oftentimes. So you may have this release of either loose or more rigid particulates in the form of pipe scales. So these particles basically are released under certain episodic often conditions, some transient, let's say, processes that are not easy to capture via the regular sampling, the regular and currently in place sampling schemes by the drinking water authorities. And if it is a small issue, it will often go unnoticed and with little damage. But there were some cases like the Flint case or the Washington DC, for example, another case of violation of drinking water rules due to distribution system originating pollution, that it may become a very big public health problem. So these are some examples of contaminant release ranging from copper, lead, aluminum, or even vinyl chloride in a city in the US. Of course, not only chemicals may be released from water distribution systems, but also microorganisms. Amoeba, Legionella, Cryptosporidium, these are only some very important examples that I put here. The very famous Cryptosporidium release that resulted in many deaths and many cases, gastrointestinal illness cases in the city of Milwaukee in the US. So we have the case studies, so we know the risks that are part of these issues. And this deterioration of Finnish water quality may occur via these aging water supply networks. So you can see here on the right, this picture, you see the internal, let's say, cross-section of a drinking water distribution pipe, where you see the formation of the pipe scales that have formed internally the pipe that carries water. So these pipe scales might be alone, and they might be acting as sources of chemical release, or they might act temporarily or in the long term as sinks for some contaminants that are part of the Finnish water that flows through such pipe systems. And these scales, they might also coexist, often cases, in the form of conglomerates together with biofilms, together with a biomass that can be not easily captured with ATP analysis, for example, in order to characterize the microbial populations that typically resides in these pipe scale and biofilm conglomerates within the internal walls of the distribution systems. So these pipe scales and biofilm conglomerates are actually have reached some kind of a dynamic equilibrium with the flowing water through the years, assuming that we have a stable and reliable provision of water to the consumers. Somehow you have set up very firmly the protocols of treatment, and you are using, let's say, specific treatments. The water source is single, does not vary in time. I'm making now like a best case scenario. I'm not changing anything in my treatment. I'm not changing anything in my sources of water. Therefore, I should expect that over time, I'm somehow reaching this dynamic equilibrium between the flowing water and the inner walls of pipe scales and biofilm conglomerates that may form over time in these aged pipes. However, imagine if you have some subtle change, you're changing, let's say, the disinfectant, or you might change, for example, the water source by changing the percentage of volume of water that you're using from one source and from another. Or you might be required to stop provision of water for a few hours every week to a particular area of the city because there is such an increasing water demand that you cannot afford to 24/7 provide water to all areas of the cities. Or you have some issues in the cities that require repairs in the pipes, and therefore you often have to turn off the provision of water. So these changes, let's say, in the non-stop provision of water flowing through this pipe might disrupt this equilibrium, this apparent and dynamic equilibrium between these particulate conglomerates and the drinking water quality of the water that flows through the systems. And as such, you might end up with some releases of chemicals or microbes that we discussed before, and we actually evidenced in some countries over the years. So these issues have to be followed very, very carefully up from the stakeholders, from the authorities, and we need to better study these episodic changes, these small changes in a parameter up in the source of the water or at the treatment level, all the way down to the tap. Therefore, these water safety plans are very important if done properly together with their risk assessment provisions and exercises, because it can be really helpful to identify such scenario, and for each of these scenario of higher risk to have a specific intervention and what are the control options for each case that is relevant for each hazard. Other issues have to do with swimming, indoor swimming in particular, but also outdoor swimming and the various disinfection practices. This is also something emerging. Then the influence of industrial activities and the water pollution events that occur near industries. The PFAS, water contamination, you probably are aware very well about the C8 lawsuit case in Ohio, or the contamination of the drinking water of US marine camps that resulted in carcinogenesis in some major camps in the US because of the volatile organics being released into the water source used for drinking water purposes. Or another case in Greece that I was part of the team that investigated the hexavalent chromium contamination and its association, its ecological association with the cancer mortality and cancer morbidity in this area, this industrial area outside the capital of Greece, Athens. Another major issue to mention here has to do with the fact that smaller areas of the city, as I mentioned before, might be characterized by variable water quality. Therefore, we need to pay attention to sample these small areas, to monitor these areas, and to properly assess and calculate the risk associated with these small areas, and accordingly then plan to spend your resources in money and people to the more higher risk areas, rather than having one uniform and homogeneous, let's say, allocation of resources for drinking water issues in a big city. For example, we have here some maps that show how variable the disinfection byproduct formation is in the city of Limassol, where I'm actually making the presentation from. At the household level, we collected water samples from different households in the city. This is the urban part of Limassol city. So the sea is right here on the white part. And then you see with different color the concentrations of total trihalomethanes, brominated trihalomethanes, and also the residual free chlorine that was present, as you can see here. So this variability again proves the statement I made earlier that within the same city you might have a totally different drinking water distribution and quality, and therefore you need to be aware of this variability and being able to understand and explain this variability, and accordingly to propose remedial measures or control options. The same, you can see that also for the same setting in the urban center of Limassol, the distribution of coliforms to the left, total viable counts at 22 and 37 degrees Celsius, and in parentheses are the number of households from which we sampled and we monitored this again, this varying microbial load in the city. Therefore, each area here, let's assume that it is one zip code or one quarter, depends what is the administration unit in your city. So which zip codes or which cities, small area values of coliforms, for example, you are going to use to report to your government, to report to the European Union. You need to think about these issues because you cannot assume that you're going to have an average value of this coliform distribution without considering the variance, the standard deviation associated with this. Because here you might have some areas that have very low coliform counts, and you might have some other areas with very high coliform counts, and in the middle, let's say the mean values of coliform values. So how do you treat these different risk areas within the same city? These are questions that I believe are important to tackle. In addition then to the space variability that you see for different indicators of drinking water quality, you might also have variability by season for the same area. Let's say we chose here a particular area in Limassol that goes outside the city here, and that also includes some areas from rural and peri-urban areas. So you see on the left, you can see the summer sampling for enterococci non-compliant samples, and visually you can see that we had more frequency of non-compliant enterococci samples in the summer than the winter from the same exact locations that we sampled in both winter and summer. Therefore, season is also very important, and therefore during summer, more sampling and a different kind of sampling campaigns perhaps should be in place. In addition to these seasonal effects, we might also have some different effects from European region as you go, let's say, from north to south. So we took some samples from Norway, and we measured them inside there, the chloroform and the brominated trihalomethanes. So these are actually values not in water, because also some northern European countries do not use chlorine, they don't chlorinate their systems. These are part of urine samples. So you can see that as you go south to Europe, the concentrations of these disinfection byproducts increase. So moving from the products that are also part of water, but are also part of other disinfection activities that take place in houses. And another issue that I would say it's of emerging importance is that sea level rise threatens the groundwater bodies near coastal zones. And we know already that about half of the global population uses groundwater as the main source of drinking water. And even more, 2/3 of the world cities, the large majority of the cities on Earth with populations over 5 million are located where? They're located in coastal areas where you have this pressure of the sea level towards the coastal groundwater supplies. And this pressure actually causes infiltration of seawater, which is also coupled with overexploitation of groundwater for agricultural purposes, right? And this results in the introduction of sodium, of bromide, iodide levels, that on one hand sodium will increase water salinity, on the other hand bromide and iodide are important precursors for the formation of the more toxic disinfection byproducts. Therefore, we need to pay closer attention to these coastal area groundwater bodies and how this would eventually perhaps influence human health. The bottom figure that we have, these are some unpublished yet. This is under review work of ours, where we actually collected data of drinking water quality all over Cyprus, and we dichotomize, let's say, the sodium concentrations in drinking water in those areas that were considered coastal, within 10-kilometer distance from the seawater front, and the other areas that had distance more than 10 kilometers. So they were not considered coastal. And what do you see here on the x-axis is an 11-year period from 2009 all the way to 2020 in the end of the x-axis. On the y-axis, you see the drinking water sodium levels. And interestingly, we saw this significant gradual time-governed increase of sodium in the water supplies of coastal, in particular areas. This, we believe, deserves more attention to study carefully. And why? Why is that? This is because the drinking water salinity is actually maybe associated with the incidence of high arterial blood pressure and with the risk of hypertension. And there are some epidemiological evidence that we recently compiled in a scoping review where we saw 15 studies from the globe showing positive significant association between drinking water salinity and higher blood pressure and or risk of hypertension. And these were important findings, especially if you couple that we also saw some negative significant association. So that means the higher the salinity of drinking water, the lower was the blood pressure. But this was mainly attributed to the fact that the higher drinking water salinity was not due to higher sodium, but this was due to higher magnesium, calcium, and potassium levels in water. So these changes in blood pressure at the population level matter. They might not matter at the individual person level. They might not matter for a single person assessment by the clinician, but at the population level, if you consider reductions or increases, let's say, blood pressure by a few points in systolic blood pressure, this has been calculated via risk assessment exercise and a health impact assessment exercise to basically show benefits for cardiovascular disease and all-cause mortality by lowering, for example, 3% the number of deaths. This 3% lower total mortality risk for the adult population, 45 to 64 years, would mean less 12,000 annual deaths just in that age range. So we believe this requires more attention by public health officers, officials, and researchers to study in more detail, particularly for coastal areas whose water supplies are in direct, more or less, contact with seawater. And trying to put now all this into a perspective, we see that considering the water quality, the air quality, together with the ecological drivers of the planetary health, like climate change, global pollution I mentioned before, land use change, I also mentioned before with the urban encroachment. So you have all these ecological drivers that put enormous pressure on the proximate causes of disease, which is basically our environment, is our food production system, is the air quality, is the water quality. And these ecological drivers affect and put a pressure on drinking water quality, and depending on the educational system, the drinking water infrastructure that is available, the socioeconomic status, then eventually will impact human health. So how do we move forward? I mean, there are some important challenges that I believe we should continue working on in the future. One of them has to do how we're going to deal with that variability, this uncertainty of a continuous supply system of drinking water of satisfactory quality under a changing climate. How are we going to deal with these transition time periods before and after subtle changes in a drinking water distribution system parameter from the source all the way to the tap? This is a major issue. The mix optimization and management protocols, especially for limited water sources, where you often have to change mixture composition, change sources, etc. This requires a lot of attention. Aging drinking water distribution systems, also very important. The influence of novel water treatment technologies, this also has to be better understood. The new disinfectants, for example, needs to be better understood by monitoring this influence all the way to the tap. You have to go down to the tap level at the individual household level to understand how these water treatment technologies might influence the overall finished water quality. With respect to the drinking water and health aspects, there are some important findings that took the place of recommendation, took the form of recommendations in a recent water forum, international water forum that took place in Cyprus a few months ago. So most of the participants that came from the academia, they came from the government, they came from the private sector, especially from the Mediterranean region. We all agreed that we need to implement risk assessment studies by all water suppliers and to actually have guidelines on how this risk assessment shall take place by the water suppliers. A very important emphasis was given on Legionella control framework. There are several priority facilities currently that we know very little how Legionella is controlled and to what extent. Training of these individuals is highly important. There are some countries that have some kind of a water safety council that manages and coordinates and monitors various water crises and water safety crises that I believe are important to be present at each region. Technological upgrades, there are many outdated desalination systems, water supply networks and facilities all over Europe. We need to upgrade these outdated systems. We need to inform consumers about the quality of water that we are offering to them for human consumption. And we also need solutions at the household level to reduce corrosivity or deposition of salts for this finished water, and how to maintain the various household water installations that nowadays we see the market is flooded. Call them point of use filters, call them other kind of installations taking the form of water softeners. These are important installations that we don't pay much attention to the maintenance, and we might end up at the household level to risk the finished water quality safety if not proper maintenance takes place. So we need to inform also the public about that. Moving to the drinking water management pillar, we need to explore means to reduce increased consumption. This is a very important issue, particularly for the Mediterranean and other water scarce regions of the globe. In Europe, there is a new and updated drinking water directive. So we need to inform the public what this new directive is all about. Third, we shall promote the use of innovative technologies, smart water meters, sensors, telemetry systems in drinking water networks. This can only make our life easier, will only give us a better monitor capability to monitor fluctuations in drinking water quality in order to efficiently control any problem. A consumer information platform, yes, why not? This is important to have. And lifelong learning issues for all stakeholders for water issues from the source to tap. I have 2 more slides and I'm finishing. Another pillar that our forum tackled, and I would say has not been adequately tackled by the research fora globally, is the linkage of drinking water and climate crisis or other crises that may occur, taking the form, for example, of various natural disasters, floods, forest fires, earthquakes. Do these impact water quality? Yes, they do. Do we somehow monitor water quality to safeguard public health? Yes, there are some protocols, but we need to do a better job in emphasizing this triplet of emergency management: prevention, preparedness, and resilience. Here, about how to mitigate the impact of disaster risks, we need risk assessment exercises. We need adaptation plans to be updated to these new climatic conditions. Third, early warning systems. Very important to consider also how this will affect water source, water quality, finished water quality, and tap water availability. And of course, invest in education and awareness program. So thank you all for your patience listening to me. I would like to thank the CI team, Dr. Harsiadis, Dr. Andrianou, Ms. Konstantinou, Ms. Xeni, Mr. Abimbola, Mrs. Ioannou, Mrs. Haddad, and Dr. Christofi, Dr. Kyriakou, and Dr. Panagiotou for their help in helping me actually present all this research to you. Thank you.